and put them under anesthesia. They might have medications like DIBS, Dilantin, or Theophylline that we need to know what those levels are to make sure they're safe before we take them into that procedure. All right, any questions on the pre-op assessment? Okay, so informed consent. We've talked about this a little bit, but we're going to go into more detail just because in this context is where it's most relevant. Obviously, we talk about consent when we talk about any admission, including admission to a mental health facility. But in this case, we're talking about the client being informed about the surgery and what the surgeon is planning to do. So basically, the provider, the surgeon, must explain the procedure. He or she must explain the risks, the benefits, and if there are any alternatives to the surgery that could equally be an option for that client. The nurse can answer questions after the fact or clarify or redirect those concerns back to the surgeon. In other words, based on what the surgeon tells them is what the nurse can operate off of. In order for a client to make sure that we're not giving we're not removing the wrong body part, during informed consent, either the surgeon or the patient takes an indelible marker and marks the correct side of the body. So because we have a left and right arm or left and right foot, or we have a left and right side of the chest, then whatever the person is consenting to gets marked with an indelible marker, so that when they go to do the surgery, the whole surgery team can confirm this is the one that we're supposed to do. I had a very good surgeon friend, an orthopedic surgeon. He was very good. And many times clients come with ortho problems, especially arthritis like this patient had, and both sides of the body are equally malformed, if you will, okay? So unfortunately, that was before surgery sites were marked, and unfortunately, he operated on the wrong foot first. And even though that foot was going to be operated on at another point, the patient did not appreciate that, and it cost that surgeon dearly for that mistake, okay? So the requirements in order to be considered legal is the patient must sign the consent form before they receive any mind-altering med. So that includes pain medication, that includes any anxiolytic medication, etc. The client has to be older than 18 or emancipated. I think we're at Enid. Enid, what does emancipated mean? Legally separated from the parents, okay. I like that. Can you give me some examples of that?
They're legally considered adults.
So they've married somebody that's 18 years.
Okay, so they're married. That's one way you can be separated from your parents.
If they've
What
been
else?
in the state of Oklahoma, if they've been pregnant or had a child, I think.
Okay, so if they've had a child and are personally financially responsible for the rearing of that child, okay? How else?
They've gone through a court.
I couldn't understand that one. Say that
She
again.
said they had gone to court.
Yeah, possibly, yes, but I'm thinking about two other definitions besides that one.
Judge of Poland.
You think of what they are? Any person who's serving actively in the military is considered emancipated. They can sign their own consent. If you can protect their country, then you can consent to your own care. And then lastly, anyone who is self-supported, meaning they live on their own and their parents are not providing them financial support. Okay? And then lastly, this seems obvious, this is the duh, that person has to be competent and conscious. Okay, so meaning that a patient who has had a traumatic injury and may be fading in and out of consciousness may not be the person you can get consent from. And then recognize that those clients who are not emancipated, a parent or legal surrogate can indeed sign that consent, right? All right, pre-op teaching. Okay, Mrs. Martinez, I think it's your student right now. No?
Nope, not me.
Okay.
I
Okay.
just hit it right before you said that though, so.
Oh, okay, sounds good. All right, so pre-op teaching. Pre-op teaching involves primarily preparing them for that post-op time. So pre-op teaching is helping them to know what to expect during that perioperative period. Okay, so what's going to happen as far as hospital routine? What kind of sensations might they experience? What's the timetable or anticipated sequence of events? Okay? And then they need to know what will be expected of them. And so during that pre-op time, we need to let them know that they need to be NPO after midnight. So some sources will say 6 to 8 hours, some will say 8 to 10. But basically, we're talking about an extended period of time where they do not eat, drink, or smoke. Okay? They may be expected to do a surgical bath. Examples of that is a Hibiclens or an antibacterial agent that will disinfect some of the surface bacteria to minimize the risk of a surgical site infection. And then a surgical prep, and that depends on where the nature of their surgery is. We used to shave the hair on the body, and we discovered that the little minor nicks that would cause in the skin led to infection during the post-op time. And so now it's required that we clip the hair with electronic clipper or dilapidatory. I don't know if I said that right. As opposed to shave it. If it is to be shaved because of the nature of the procedure, then it must happen under anesthesia, and it must happen after the site has been disinfected and used a sterile razor during that process. Okay, and then there may be a bowel prep, vaginal prep, or some other prep that the patient may be asked to do as well. And then there may be specific tests or procedures that the client may have to do even as much as a week prior to the procedure, depending on the nature of the procedure itself. And then during the post-op time, we need to help them to know when they're going to get to eat and drink after surgery. Now, some surgeries, it's as soon as they're awake and alert and the nausea has passed, and they can go back to drinking and fairly quickly. For others, because of something we'll talk about a little bit called an ileus, it might be 3 days before they'll be able to eat or drink. And patients need to know that because they've already gone without food and drink for several hours before they came. They need to know that their pain and comfort is going to be managed. And so I think we're at Stillwater. What is a PCA? Patient controlled, say it again? Analgesia. Yes, patient controlled analgesia. It's simply an IV device that allows them to trigger a dose of medication so that they can manage it before it gets too severe, as opposed to putting on a call light and waiting for a nurse to bring them something. Research has confirmed that a well-utilized PCA by a client will actually minimize the amount of pain medicine they receive or require and will promote their comfort better than a nurse can giving intermittent injections. They need to know what's going to be expected as far as activity. And so if they're going to be bedfast or on bed rest for a period of time, we need to teach them how to do their leg exercises to minimize the DVT. If they're not, we need to help them know what mobility is going to be asked of them. For example, some clients would be shocked to think, you're going to do what? I'm going to get up in a chair when this is all over at the end of the day? Or I'm going to walk in the hall before I go to bed tonight? And so they need to know those things ahead of time. Respiratory hygiene, we talked about that the other day. So turn, cough, and deep breathe. Remember, we can teach them that, but incentive gives them a visual feedback so they can tell how deep they are breathing. And so incentive spirometry or turn, cough, deep breathe helps promote respiratory expansion and minimizes the risk of a respiratory post-op complication. And then visitors, they need to know what's the visitor policy during the PACU time, during the time that they might be in the holding area prior to the surgery, and then visitors if they are admitted to the hospital. And then lastly, if we know based on the procedure and the surgeon, things that will be expected that the patient will have after they come out of surgery, things that might seem very benign to us can be very frightening and terrifying to a client coming up from anesthesia. So helping them to know ahead of time, you might see this, or you might have this, and don't be frightened, it's for this purpose, and explain that to them. Recognize that when you're doing pre-op teaching, we only provide the patient as much information as they want to know and that they need to know in order to prepare them safely for the procedure. We don't simply provide them everything that we know because their anxiety would simply go out to see them. Okay? And then the surgery checklist. Best practices say that there should be a tangible, either electronic or paper form of a checklist in order that all things that need to be done during that immediate pre-op time have indeed been checked off. So the first thing is the consents. Recognize that not only do we have informed consent for the surgery, but the patient may require a blood consent as well. And so it's our responsibility as the pre-op nurse to make sure that those are indeed have been signed and are in that record. The client needs to have their ID band on. If there's a possibility that they might need blood, if they've had a type and screen or type and cross match, they will have what we call a blood band, and that should be in place on their arm. If they've done an autologous donation, meaning they came in over the last 90 days and donated their own blood so they could use it if they needed it during the post-op time, there should be a blood identification for that as well so that they only get their own blood. And then if they have any allergies, they should be listed, and then that site, if there's a left and right, then it should be marked with a permanent marker. And then there's specific things that should be on the chart for anybody in that surgery team to see. That's their history and physical, any of those lab reports or diagnostic x-rays or CT reports, as well as medication administration records. So anything the client may have received preoperatively or meds that they may have taken at home the night before because it's their routine meds. And then if there were any preps done, and that includes any pre-op meds. So there are sometimes pre-op meds that are ordered specifically on call to the surgery suite or on call to the OR unit. And that might be a dose of prophylactic antibiotic. That's part of the SCIP project. Okay, so with a client who is going to surgery is supposed to receive a prophylactic antibiotic within 1 hour prior to the incision being made. That's one of those SCIP items. And so we need to document that so that the surgery team knows that it was already administered. Okay. And then any clinical data, so any vital signs or other things, IVs that we've started, fluids or anything else that we have initiated on a client needs to be available for the surgery team as well. And then lastly, before we turn that patient over to the perioperative nurse, we're going to give a verbal report, and we're going to include the documentation that we just talked about, either electronic or paper or both. And if there are any abnormals that need reported, that's when we need to make sure the surgeon and anesthetist knows about those abnormals so they can address them before that person goes under anesthesia. Okay. I think that's a good stopping place. Let's come back at 1:30 and we will pick up there.